Special Sunday edition of Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, a reproductive endocrinology and infertility specialist. On the other side of the camera is my good friend Tarek Ibrahim from Ibrahim Strategies Group, our social media guy and the guy that asks all the questions. So we're doing it tonight because I am off to Ireland tomorrow for the British Fertility Society meeting. And as a result, we thought we'd do our show tonight, get a chance to answer all your questions before I go away. Hope you all had an amazing holiday season. Happy New Year to everybody. Hope you had a great, safe, wonderful holiday, very rewarding and restful. And hopefully everybody got you the presents you wanted and none of the ones you didn't want. I saw a great TikTok of this little kid, about 5 years old, absolutely swearing his head off because he didn't like the present he got and swearing off Christmas in general. So it was quite humorous to see. So hopefully none of you had that kind of Christmas. Everybody got a nice gift. Happy birthday to my wife and my dear friend Carrie Mayrand, who were Christmas Eve babies. And we celebrated Wendy's birthday, waiting for our kids to arrive from BC because we had the storm and it was a nightmare. So in any event, tonight we're just going to take your questions. I have been scanning the literature for something new and amazing, and there's actually very little new and amazing coming out over the holidays. So nothing really brilliant to reveal to anybody that we didn't know before. And so just kind of thought we'd take questions and try and answer as much as possible. And then next week, I'll probably do a recap of things we learned or saw at the British Fertility Society meeting. So if we don't get anything new, that's what we'll do. I did reach out to someone quite well known and famous on the social media or in the social media world in regards to joining us on the show. So we're just waiting for her to respond. And if she says yes, then we'll get her on the show as well. So yeah, welcome to Fertility Fact or Fiction. And I think Tarek has some questions to ask. And of course, as always, ask your questions. Please just ask on one platform. Don't jump platforms. It takes us a while to get to your questions, but we do try and get to all of them. And if we don't get to your questions, we take them all down and we try and answer them later. So we will do our best. And I'm ready if you are, buddy. How are you doing? Did you have a good holiday?
Great holiday.
Tarek did the vacation with the wife and went down to Miami, right?
That's what I did.
Good trip? Absolutely. Nice weather, you said?
28, 29.
Oh, very nice.
That's all you need.
Now, were you on the beach or did you have to walk to the beach? Or
right on it.
Right on the beach.
Right on
very,
it.
Very nice.
Yeah.
Cool. White sand, hot.
White sand, hot.
Cool.
Got too hot, had to go in the water to cool off. Came back, dried up, and sunned it in. So
very nice, very nice. Sounds good. All right.
Canada is not as good to me as America was that day.
Very cool. All right, I'm ready if you are.
Okay, here we go. First question from Instagram.
Okay.
Dr. V, when am I safe to do my FET after contracting COVID? And what if I push it back and contract the flu?
Well, anytime you have a major infectious thing, at least a couple of weeks, but with COVID, we normally recommend about 2 months. Now, there's no evidence for that. In fact, the evidence actually supports going ahead directly because they've looked at people that got COVID or got vaccinated and there was no problem. But we do know that there's this huge immune response to COVID and the vaccines from COVID. And as a result of that, we are telling everybody to just wait the 2 months and then do the transfer so that your immune system's going back to normal. Your immune system is a vital part of your fertility. And we all know that it's an important part and that it's critical that it be kind of working in a normal or reasonable fashion. So we don't want it to be on overly and we don't want it to be off either. We just want it to be working in moderation. And when you've caught something significant like the flu or COVID, it can actually kind of mess that up. So we would recommend you take a little bit of time. A little bit of time would be 2 months. In the COVID studies looking at vaccination, that's when you can see the antibodies coming down. So for us, that made the most sense for a time span.
Hello, Dr. V&T. Just a bunch of hellos and Happy New Year's.
Excellent. Happy New Year to everybody. We love you all.
Thank you for all you do for us, Dr. V and Maestro T.
Maestro. Oh, I think that's a new one. That's a good one. Yeah.
How long after salpingectomy and an endo excision do you generally suggest an FET?
Oh, actually pretty soon. So the key with the salpingectomy is it's irrelevant, actually. You can get, pregnant right away. But the endo excision, you've only got about 6 months before potentially the endo is coming back, certainly within a year. So you would want to do it within 6 months to a year. Now, in our practice, we suppress our patients after we've done the endo surgery. So we do 3 months of Lupron and letrozole, and that Lupron and letrozole combo really turns off any residual endo that may be there. So we find that that's really helpful, and there's some evidence for that. So we would kind of do your surgery, do the treatment, wait the 3 months, and then start right away with your embryo transfers at that point.
Happy New Year, Dr. V&T. Is it normal to have a period after your first depot Lupron injection? Thanks.
Yeah, so it depends on when you took it, but it would be very normal if you took it on like day 21 of the preceding cycle. Then we're expecting you to have a period. That one was an easy one.
Yep.
By the way, I did the 40 and Infertile podcast yesterday with our friend over there, and we kept it going for 2.5 hours. So she's going to give us the video, and we can post that on our YouTube channel too. Great. So yeah, it was cool. Talking all about embryo transfer protocols with her.
Related, endo ER protocol, question mark.
So an endometriosis egg retrieval protocol. So the studies would support doing Visan, but not Lupron for 3 months prior. We don't recommend super high doses, like a medium dose of gonadotropins. You should probably use letrozole throughout the cycle to keep your estrogen levels relatively low and not overstimulate your endo. Always double trigger. We're always big supporters of a double trigger. So that's a GnRH agonist like Lupron, which is no longer available, or Suprafact or Buserelin or any one of these products that we're currently using, Triptorelin, and then a little bit of HCG as well. And then never a fresh transfer. That always drives me crazy when people are doing fresh transfers for endometriosis. So frozen embryo transfer, when you get to the frozen embryo transfer part of things, a letrozole protocol, again, lots of natural supplements, NAC, coenzyme Q10, curcumin, resveratrol. Get your progesterone levels high once your lining is ready, much higher than normal. So for endometriosis patients, higher progesterone levels are actually more successful than the average progesterone levels are.
Does endo always result in a hysterectomy? Hysterectomy. Yep, that's from TikTok.
No, I mean, it depends on what your goal is, right? So there are natural treatments for endo, which we actually have a video on our YouTube channel about. There are medical treatments, things like Visan, birth control pill, Lupron with add-back therapy, Orilissa, there's a whole host of them, Depo-Provera, Mirena IUD. And then there are surgical therapies, and surgery can be focused on actually operating on the endo and just removing the endo, or it can be focused on hysterectomy, which is definitely one of the better techniques for relieving pain, but doesn't apply to everybody, because if you're trying to preserve your fertility, we're not going to take out your uterus. So not everybody with endo needs a hyst, but some people will want it eventually because their pain is so bad. And it's certainly something we have to talk to patients about, but it's not something we ever encourage because it is major surgery and there are alternatives. So you have to offer patients all the knowledge about all of the options. What are the risks? What are the benefits to each choice? Make sure they're aware of all the different choices and then let them make their own decision. That's the way we practice anyways.
Sorry, unrelated to the topic, but what do you suggest for perimenopause?
Oh, well, that's a great topic. It's a big topic. So perimenopause, if you're looking at treating yourself hormonally in order to minimize the symptoms of hot flashes, night sweats, mood swings, vaginal dryness, sleep disturbance, decreased sex drive, there are two approaches. So there's hormone therapy, and then there's non-hormone therapy, like natural things. So all of the natural things, black cohosh, all of that stuff, it's all being tested. None of it works. So they've done randomized controlled trials, not a shred of evidence that any of that stuff works. So don't try that. It's a waste of time. So if you're going into the hormone therapy, it's, do I want synthetic hormones or do I want the bioidentical? So the bioidentical people will tell you that theirs is better, it's safer, it's more natural. None of that is true whatsoever. There's no proof that it's better, safer, or more natural. So you can use it, it's fine, but it's got the same risk profile as the synthetic stuff. And so whether you're taking bioidentical or synthetic, you're taking hormones. So if you have a uterus, you're taking estrogen and progesterone. And if you don't have a uterus, you're taking just estrogen. For the people that are taking just estrogen because they don't have a uterus, it's actually quite safe, beneficial, reduces risk of death, heart disease, cancer, even breast cancer. For the people that have a uterus and are taking estrogen and progesterone, it's great for your bones. It's great for all the menopausal symptoms. It's very good for your heart, we think, as long as you don't have pre-existing heart disease, you're not a smoker, high blood pressure, high cholesterol, diabetes, that kind of thing. But it is not good for breast cancer. So based on the Women's Health Initiative, which granted is probably the worst conducted study in history, but nevertheless huge, there was an increase in the risk of breast cancer. Also, the Million Women study from England showed the same thing when you were using estrogen and progesterone. So you do need to be cautious at the very least if you're using a combination of estrogen and progesterone, because there may be an increased risk of breast cancer, especially in the early phase of it. And so we are cautious about that for people. There are a couple of alternatives. There's a drug called Duaviv. It's got a low dose of estrogen combined with an anti-estrogen. So the beauty of that product is it's anti-estrogen in your breast and it's pro-estrogen everywhere else. So, and it's a little bit anti-estrogen in your uterus as well. So the nice thing about that is it actually can allow you to not get breast cancer and not need to take progesterone and just take an estrogen-based product. So I've always been a huge fan of that because it makes a lot of sense and it should be safe. It was great. We were using it quite a bit. It went off the market for a long time and I think it's just coming back now. So I think I'll start prescribing that again now that it's available because that was a really good product and I believed in that one for sure.
Thoughts on using frozen embryo and implanting on day 5 of a new IVF cycle?
Oh, definitely no. So a new IVF cycle is going to have very high estrogen levels. And because your estrogen levels are really high, your lining is generally going to be out of sync. So if your lining is out of sync, then your chances of the embryo sticking are much lower. Even if it does stick, the risks of intrauterine growth restriction, IUGR, preeclampsia, miscarriage, complications related to high estrogen levels are much higher. So we never advocate for a fresh embryo transfer if you've made a lot of eggs. If you're not making a lot of eggs, you're only making 2 or 3, sure, it's totally reasonable to do that. But if you're making several, don't do it. It doesn't make sense.
Thank you for everything you do. I hope you know how much you are appreciated.
Oh, that's really sweet. Thank you.
Dr. V and T-Man.
T-Man.
How different.
You know, I got to put up with a whole year of you finding new ways to be named.
Well, you know, the beauty is we actually have the ability to get so many great nicknames for
I know, there are some good nicknames.
Yeah.
What was that one we needed to make t-shirts out of? There was one we talked about right before.
Batman and Batman.
Was it Batman and Batman?
Can't go wrong with that.
No, you can't. That's good.
You know, it's interesting that you bring that up because the other day my wife was like, oh, you know, she said something and the conversation is like, oh, I'm like a superhero. That was her. And then, you know,
Wow,
I mumbled, you're more like Robin. And all the kids started laughing. It's like, well, what's wrong with Robin? And then everyone said, nothing's good about Robin. So that was a pretty funny moment.
That is good. I like that one. Yeah.
Thoughts on, Dr. V and T-Man, how different are day 7 embryos?
Yeah, they're definitely not as robust as day 5 and day 6 embryos. So it does depend on what study you read. There's like one study that says that the results are the same, but the majority of studies show a very significant decrease in success rate. And that's assuming they're genetically normal, because the chance that they're genetically normal is much lower for day 7 embryos than the day 5s and day 6s. So if you have a genetically normal day 7 embryo, I believe it has a much lower chance of success, but there's one study that says it's the same, but the chance that your embryo will be genetically normal by day 7 is lower. And I do believe the other studies that said that the chance of a day 7 being as good is actually not true, that it's not as good, even when it is genetically normal.
Thoughts on using frozen embryos and implanting on day 5 of a new IVF
You asked
cycle?
me that
That one?
just a moment ago, yeah.
Okay.
Yep.
Okay, we scrolled up too high. Thoughts on low dose IVF stimulation meds if doing for genetics and no fertility issues. Thoughts on omnitrope with low percentage of mature eggs fertilizing.
I don't know what you mean by genetics. If you're doing it for PGT because you're worried that your embryos are abnormal, you want as many embryos as you can get, because the more embryos you make, the higher the chance you'll find some that are normal. So I would definitely be focusing on making more, not less. You never want to take too high a dose of gonadotropins, but low wouldn't make sense. If you're doing it for sex selection, that's a different story. You don't need a lot, so you could just take a lower dose for that. As far as omnitrope, one of the benefits of omnitrope in studies is that you end up with more mature follicles. So the answer to that is a slam dunk yes. You should definitely be using omnitrope if you didn't have mature follicles, and we do that all the time with very good results.
Dr. V&T, is perineal massage beneficial?
Yeah, so actually it is. Perineal massage, where you are, forgive me for the gesture, stretching out the bottom of the vagina in preparation for delivery of a baby, that actually has been shown to be beneficial. So there is a study that actually demonstrated that that is beneficial. Tarek is trying to look at me over the computer, and I'm going to crack up. Anyways, so yes, that is beneficial, and it can help, and it should be done. I'm probably going to get executed from several of my friends for saying this, but sometimes the midwives are way ahead of the OBs in some areas. Definitely not all, but in some. And so that's something that has come out of midwifery, that perineal massage can really help. So if you are comfortable with doing it, it's definitely a good thing to do to avoid tearing. Does it have long-term detrimental impact? We don't know. That's not something that's being looked at. Like, could the vagina be looser afterwards? Probably. I don't know. No one's ever studied that before.
Dr. V&T, we are so happy to have you back. Dr. V. This is the question. That was the intro, and now the question.
Very nice. Yeah. It's good
Dr.
to be
V,
back.
Yeah. Dr. V, I have pain in my growing after ovulation these last few cycles.
Okay.
Anything to worry about? I am eagerly waiting for our regroup.
Well, if it's pain, I can't see who you are. Tarek knows, and he's not going to broadcast your name. So if you have pain after a fertility treatment, then we always have to worry about cysts, endo, ovarian torsion, that kind of thing. If you have pain without fertility treatment, we still worry about the same things, but oftentimes it'll pass. And if it passes, then you don't need to worry. So sometimes you just get a cyst that lasts a brief period of time and then it goes away. So I'm not worried by any means, but just give the office a call if you need me to check you out, and we'll definitely do that.
I got a doozy here for you.
Uh-oh, okay.
You know, some of these questions, when I read them,
Yeah.
I'm actually shocked that there's doctors that have difference of opinion on these things.
Oh, okay, all right.
Okay.
Oh, that's a good, like,
That's a good intro, right?
I need a drummer roll here.
Okay,
Okay, go for
Dr.
it.
V&T.
Okay.
I told my IVF doctor about fertilizers.
Okay.
She didn't seem to think that testing menstrual blood was better than taking a biopsy for receptive DX, which is better. How could I convince her?
God.
See? I'd probably like it.
Okay, so Receptiva DX is useless. It's been proven to be useless, so don't bother. There's no point in doing that. Ask her to provide studies demonstrating that it works. There are none. Well, I shouldn't say that. There are some, but they're useless, and there are studies showing that it doesn't work. So that are much better done than the ones that showed that it was beneficial. So Receptiva does not work. With regards to Fertility, there aren't any studies, so I'm happy to admit that. However, it's not really needing studies because it's not a test that's looking for some kind of subjective thing or whether a certain level of something is, affecting your risk of having endo or chance of implantation. It's literally telling you yes or no, do you have low, medium, or high levels of a specific bacteria by checking the DNA of that bacteria. Those bacteria do not belong in your uterus. So if you have high levels of them or moderate levels of them, they need to go. It's not a question that even needs study. We know that that's not appropriate. So I'm a much bigger believer in Fertility than I am in most of these other tests. Enough that we're actually looking into buying the equipment to start doing it here because we found out how to do it, and we'll probably have that by summertime. So yeah, like the infection testing from biopsy is useless because you're getting a pathology result or that crazy Receptiva stuff or ERA, and none of those are useful. So don't do that. You need to actually have collection of menstrual blood so you can actually see what the concentration of bacteria is and what the actual bacteria is in the uterus. That's how you figure things out.
Thought you'd like that.
Are we getting people on TikTok tonight?
Yeah. Can you comment on Emma ERA Alice testing? I think you have said ERA is not effective.
Yeah, so ERA is 100% useless. So ERA has categorically been proven to be useless. Do not spend your money on an ERA test. In fact, in the Journal of the American Medical Association last month, they published yet again another study, which was a review of all the other studies demonstrating that it is useless. So please, please, please do not do the ERA test. Of no value whatsoever. Emma and Alice are very much like the Fertility tests. So yeah, they're useful. I just don't trust iGenomics because they're still promoting the ERA. So for me, it's hard to support them, but the test itself is valid. There's no question that if you find out what bacteria you have, you know whether or not you need to treat them.
Hi, Dr. V. Happy New Year.
Happy New Year.
After laparoscopy for endo, do you still suppress with Lupron and letrozole before the FET?
I do. Yeah. So, no matter how good your surgeon is, they're never going to get rid of all of the endo. And if you have endo that they could see, then you almost certainly have endo that they couldn't see. So the best way to quell that is to suppress you.
Will medications of IVF speed up menopause?
No. So most women have hundreds of thousands of eggs in their ovaries. Obviously, as you go through your life, that starts to dwindle considerably every month as you lose, a lot of eggs each month. However, even if you're in your 30s, you still have loads and loads of eggs. If we stim you for IVF, even if you're a crazy responder and you make a world record number of eggs, you're going to make 50, 60, 70, something crazy like that, which is totally not normal. If you still have 100,000 eggs left, who cares if we took away 70? You're not any closer to menopause, not in any kind of practical, clinical sense.
Hi to the best team around.
Thank you. We are kind of a cool team, I must say. Yeah.
Thanks for everything you do.
Thank you.
The question is, best probiotic to take after doxycycline?
Doxycycline?
Yeah.
So we use one from a company called NFH, and their product is called Flora. But I heard today from a client that actually it's no longer made. They discontinued it, but I don't know if that's true. I haven't verified it yet. So I don't know what the best probiotic is, but I'm not sure that there is like a best probiotic because there aren't any head-to-head comparisons. So we just use the one we use. It was because our pharmacy had it available. And it did have what we wanted in it, but you could realistically get any probiotic and it's probably going to be fine. Get one with lots of lactobacillus and lots of acidophilus. You're going to be okay. Worst case scenario, use Activia plain yogurt and literally eat some and stick the rest in the vagina. But plain. Don't put in the other ones because that'll be a problem.
How many cycles after stimulated IVF to do frozen transfers if hyperstimulation?
Oh, great question. 1, maybe 2 maximum. Just wait until your hormones are back to normal, your ovaries have shrunken. Usually that's within 1 cycle, but 2 is probably a bit safer. But if your hormones are down, your ovaries are shrunken, there's no fluid floating around inside you, you're fine after your 1 month. Excuse me.
Is BCL6 BS? Last
Yes.
transfer was chemical after 2 months of Zoldax and letrozole. Should I be doing Zoldax based on BCL6 and Unexplained? Did have 1 live birth from transfer 2 MO of Zoldax prior.
2 months of Zoldax prior. So congrats on the live birth. That's great. So BCL6 is useless as a diagnostic criteria for endo, so don't go by that. If you think you have endo, unfortunately, you need laparoscopy. That's the only way to diagnose it. There is no other test. MRI doesn't work. Ultrasound doesn't work. You need to do laparoscopy. So if you don't want to do laparoscopy, is there harm from doing Zoladex and Lupron for 3 months? There's harm in the sense that it's not easy. But there's no long-term harm from it. If you're still unexplained, then I would recommend additional testing plus minus treatments. So things like, the Fertility test that we do for infections, immune system testing, and then treatments with things that are either immune or antibiotic, or the wild stuff that we do like PRP, Neupogen, human growth hormone, HCG wash, vaginal Viagra, lots of stuff like that.
Don't be shy to ask for likes today, by the way.
Oh, yeah. You know what I want to know? And send up some likes for this. What do you guys think of the top 5 finds from 2022? The little video clip I put up. Did we put that on everything?
YouTube didn't allow you to use it.
Why would YouTube not allow me to use it?
They copyrighted you for something. They completely...
How could I be copyrighted? It was me sitting in front of my cottage wall.
They did not approve.
Wow, that's bizarre.
They did not approve of it.
Maybe because did I use a technical term in there?
They knocked it right. They blocked it even.
Wow, that's crazy.
They went harder on that than the Game of Thrones video. There was something on there that just made them angry.
I don't know what that was. Yeah, so let us know what you thought if you saw it on any of the other formats that we put it up on. I think it went up on TikTok, right? And it went up on Instagram. So let us know. If you like that video, let us know. And our other videos that are blowing up on social media right now are our top 5 vitamins and our top 4 ways to improve men's sperm. Embryo math is almost at 100,000, so that's kind of cool. Yeah, it's getting there.
What would you suggest change in supplements for transfer after retrieval? Thank you, Dr. Victor T.
Victor T. Don't change any of your supplements. Stay on all the same ones. There's no reason to change your supplements.
What if you have endo and DOR? Thus far, cannot get embryos to freeze. Stage 2 endo, mostly in bowels.
So first of all, I'm sorry you're suffering from that. That would be painful and awful. I would do a day 3 transfer. I mean, if you're not making it to day 5, I would just do a day 3 transfer, frozen, but freeze them on day 3, and then do that. The other thing is, it depends on how they're stimulating you. So are they using some priming for you? Did you get birth control priming first? Because that's terrible. Estrogen priming, also terrible. Your whole protocol would be critical. What dose of gonadotropins did they give you? Were you on letrozole? Did they give you a double trigger? Calcium ionophore oocyte activation, GM-CSF media, time-lapse incubator. Like, we use every trick in the book for our endo patients. So maybe give us a call and do a consult with me, because sometimes we can introduce stuff your center hasn't even thought of or talked to you about.
Hello to the dynamic duo.
Oh, there we are again, Batman and Batman.
Mm-hmm. Yeah, that's right. Happy New Year.
Happy New Year.
We are starting a funded IVF cycle in February.
Awesome.
We had 2 failed IUIs in the fall.
Okay.
And took a few months doing just letrozole and trying from home.
Sure.
Do you think it would be okay to still use letrozole for my January cycle, or would it cause any issues with switching over to egg retrievals in February cycle?
Nope, fire away. If you want to try one more month, be my guest. No harm done whatsoever at all.
Hi, Dr. V. Is there anything that would prevent me from carrying my husband's second cousin's embryo? For example, would my blood type be a factor that would cause it to terminate?
No, anybody can carry anybody else's baby. The only time it's a problem is if there's an issue with you. So you've got an autoimmune condition, you've got, a thyroid problem, there's a fibroid in your uterus, a polyp, or if you are sensitized to the positive blood type because you're negative but previously were exposed, and then the embryo is a positive blood type, that would be a disaster. But most people out there are not sensitized. So as long as you're not sensitized, you'd be fine. And what a noble thing for you to do. So huge likes and thumbs up for you. That is amazing of you to offer to carry. Was it your husband's cousin?
Husband's second cousin.
Husband's second cousin? I mean, that's like the ultimate sacrifice. My heart goes out to you. Amazing. You're an awesome person. Wow. Just wow. That's all I can say. That's incredible. That's the kind of heartwarming stuff we love to hear about here. So good for you.
Hi, my favorite Dr. V and T. Well, I don't know how many Dr. V's and T exist, but we'll take it. 34 years, 2 unexplained miscarriages, 3 failed IUIs.
Okay.
My AMH is 1.74.
Okay. Does it say picomoles or nanograms?
No.
Okay.
No unit.
All right.
All tests came out normal. Should I consider IVF at this time? When will I know that I have to test for endometriosis?
How old is she?
34.
You can do up to 6 IUI at 34 if you're willing. I'm not encouraging you to do that, but up to 6 still continues to give you a continued increase in your chance of success. So if you want to avoid the cost or the invasiveness of IVF, there's still room to do more IUI. When should you consider laparoscopy for endo? A, if you have symptoms, and B, if you've done 3 failed IUI. I guess if you've had 2 miscarriages, I'd be wanting to know a little bit more about why you were miscarrying. So those are good opportunities to jump on a detailed consult and find out, your body mass index, your health habits, your smoking, drinking, drug use, your partner's body mass index, his health habits. What about his DNA fragmentation? Is there something wrong with the shape of your uterus? So there's a lot of work that can be done to maximize your chances with your IUI. If you didn't want to do more IUI, then yeah, IVF is a great option for you. And I think that that's a reasonable consideration, but there's room to continue along that IUI path if you wanted to. Make sure you're dealing with a good RE who will explain your options to you and tell you what additional testing is available, what interventions are available, what will make a difference, how far to go, and so on.
Dr. VNT, I sent you a message on IG last night. Have you ever done a luteal phase protocol? If so, what is the reason for that type of protocol? Also, what do you think about Meronional?
Yeah. Okay, so we don't have Meronional in Canada, so I have no familiarity with it. So I apologize, I can't answer that. Have I done luteal phase? We do it literally every month. I love luteal phase. It does work very, very, very well. Why do we do it? Patients that don't do great in their follicular phase, patients that want more eggs, or patients that are kind of slow to develop in the follicular phase, they may be better in their luteal phase. So there's a bunch of different reasons to do it. We've had patients where we got literally no embryos from their follicular and then gorgeous embryos in their luteal. So I'm a big fan of doing luteal phase stimulation. It works very well in the right circumstances and in the right hands. So we do it frequently.
Dr. V and T, I am newly pregnant thanks to Dr. V and his wonder team.
Yay, congratulations.
I am wondering if sex is okay during the first trimester.
Absolutely, yeah. Just same thing I always tell everyone, no swinging from the chandelier. So try and take it easy. If you're going wild, that's probably not a good idea because you'll bleed, because the blood vessels on the surface of your cervix are much more delicate when you're pregnant, and anything that bounces into them will cause bleeding. So then you'll panic because you're bleeding, even though it's just coming from the surface of your cervix. So gentle, I always tell my patients, like, don't have sex, make love. So you want to be really gentle about it. But as long as you're okay and you're being gentle, you're fine. You can have sex. It's not a problem.
Hi, Dr. VNT. For egg retrievals, Recovel and Menopur is good for PCOS in older age. What could be done different to get quality versus quantity, as PCOS tends to give more, but quality tends to degrade with age?
So you're actually doing the best of what we know of for quality and quantity, which is Recovel and Menopur. So Menopur is really good for quality. Gonal F is best for quantity. So that's what we've always mixed together. But in older patients, we do tend to use more Recovel. So you're on what I would use. On top of that, testosterone priming, human growth hormone, loads of supplements, vitamin D, omega-3, melatonin, iron, bucket loads of vitamin D. Like I said, your prenatal vitamin, healthy diet, no smoking, no drinking, no drug use. Everybody loves that book. It all starts with the egg. It doesn't all start with the egg. It actually starts with the sperm in the egg, and it starts with you as well. So, it's not just focused on the egg, but there is a lot to having as healthy a start to the whole process as possible.
Hi, Dream Team.
Hello.
BRCA negative, but
Awesome.
lots of breast cancer in the family.
Okay.
Any considerations for drug protocol for IVF?
Actually, first I'd do a comprehensive breast cancer genetics panel. So companies like Invitae, Fulgent, Sema4, they all offer these comprehensive carrier screen cancer panels where you can actually determine if you have another risk factor for breast cancer that is not BRCA related, BRCA related. So I would start with that. Assuming it's, you're negative for all of those things, the only thing we can control during your IVF cycle to reduce breast cancer potential risk, and keep in mind, IVF actually doesn't stimulate breast cancer. That's been studied extensively, is to keep your estrogen levels as low as possible. So for breast cancer patients who are doing IVF for fertility preservation before they go through chemo, we keep them on letrozole the whole way through to keep their estrogen levels low. So that's something you could do.
TV crew.
TV crew. I like that one. You know what? That would be good on a t-shirt. That would be very good on a t-shirt.
You all rock.
Oh, thank you.
How do you decide to transfer a day 3 or day 5 embryo for natural IVF?
So it's a discussion with the patient. If they want to know the quality of their embryo before we transfer it, then you really want to know, is it strong enough to make it to day 5? And of course, if you want genetic testing, we have to, because then we got to actually, biopsy it, freeze it, and bring you back for an FET. If they've previously failed a day 5, like their embryos don't grow to day 5 or day 6, or they did have embryos that grew there and they were genetically normal, but they still didn't stick, there's absolutely nothing wrong with putting it in on day 3. So some people will argue, if you're doing a natural cycle, what is the value of waiting till day 5? You may as well put it in on day 3, because the sooner it's in its natural environment, the better. I have no argument against that. That's probably a very reasonable thing to do, and we have done that before. The only reason we grow them out longer is because, like I said, if it doesn't make it to day 5, that patient probably needs to consider using donor eggs or being more aggressive, or whatever the case is, but some kind of alternative. So, I think it needs to be individualized, but realistically, there is no valid argument against doing a day 3 transfer in a natural IVF cycle. It's a very rational, logical thing to do.
When should you start omegas? Before ER, before FET, or once pregnant?
It's probably best to do it before ER. There is some evidence to support that it makes your blood a little bit thinner. So we may very slightly be increasing your risk of bleeding. but I don't believe that it's sufficient to stop you from using the omegas before you do your egg retrieval. And there's no question that the omegas, which contain what's called a PPAR ligand, can have a huge impact on your inflammation, which can actually have a huge impact on the egg quality. So I'm a believer in taking the fish oils.
37 AMH.
37 AMH. Wow. Woo! Okay.
Sorry. Read it all wrong.
She's 37.
She's 37.
And her AMH is?
0.2.
Oh, okay.
A little different.
All right, a little different. Yeah.
Doing duostim.
Okay.
Would you use estrogen patch plus HGH for priming?
Never use estrogen for priming. We reviewed a study about, 2 months ago, showing that estrogen priming decreases your chances, it cuts your chances of live birth in half. No estrogen priming. Testosterone priming, DHEA priming, human growth hormone priming, but no estrogen. The other thing is that, and no birth control either. The other thing is that if your AMH is 0.2, arguably all that priming is a waste of time because you're just going to make 1 or 2 eggs. So why not just do, mini stim with natural cycles? All that priming is not, you're not going to make 5 eggs all of a sudden. You might make 2 instead of 1. Maybe you'll make 3, but you probably get that same chance if you just took the stim. So I'm not a big believer in priming when patients' ovaries are that weak. You probably save yourself the hassle, the time, the money, put it all into just doing another IVF cycle.
Did Lupro depot suppression 4 months ago before FET, but it failed.
Oh, sorry.
How soon can I do another egg retrieval?
So if you did a 3-month Lupron depot and it was more than 3 months ago, you're fine now. If you did a 1 month, right away is fine. It doesn't matter. And I'm not sure why you were on the suppression, but Lupron alone prior to embryo transfer, if it's for endometriosis, is useless. It doesn't work. So don't do that.
High dynamic duo.
Hello?
For FET.
That's really getting like some coverage. Eh?
That's becoming a thing.
It's becoming a thing. Batman and Batman.
Yeah. Maybe even action figures are appropriate at this point.
2 relatively hairy Middle Eastern Batman.
Yeah. Why not?
That's all the world needs. Yeah. Okay. Go
I tell my kids all the time that they can be anything they want to be.
Yeah.
Why can't they be Batman? So for FET using a double donor embryo, what do you recommend other than birth control pills, Lupron, estrogen patch, and PIO? 44 years old.
I don't recommend any of those.
Yeah,
don't use. I'd strongly advocate for not doing any of those things. So no birth control for sure, increases miscarriage risk. Definitely no estrogen. You want to use a letrozole protocol, estrogen only if you need it, double progesterone, vaginal and injectable. Measure your levels, and a very sophisticated, gentle embryo transfer. Loads of vitamins, melatonin, vitamin D, prenatal, your omega-3s. There's lots of stuff we recommend, but definitely none of the ones you mentioned. Yeah.
That's kind of funny.
That is kind of funny.
I recommend nothing that you think I'm recommending.
Yeah.
Hi, Doctor.
I guess I recommend a different doctor because all the things you
that's
recommended are not the right ones. So yeah, don't do that.
You ready for this one?
I'm always ready.
Hi, Dr. T and Mr. V.
I quit. You come sit here. I'm going to that side.
I'm a big fan of 2023. 2023 looks good.
Yeah, I'm done. I'm out. I'm leaving the set. I'm gone. All right, go ahead.
Would taking metformin for PCOS during pregnancy help prevent gestational diabetes?
Yes.
Oh, there you go.
Yeah, it does. It'll delay it or prevent it completely. So that's a reasonable thing to do.
If I'm taking 2 mils of PIO and no suppositories following a day 6 FET, is that enough?
2 mils? Wow. Oh, that's a lot of PIO. No, it's not enough. So The way progesterone works is that it has an endocrine effect, which means it goes into your bloodstream and has its systemic effects. But it has a paracrine effect, which is it's acting on the organs right next to it, which is the uterus. So it's coming from your ovary and it's going through the fallopian tube / ovarian uterine blood supply to get to your uterus. You can't get that effect from just taking the oil as directly as you can by taking it vaginally, because then it gets absorbed right into the uterus. So you really need both. So I would be doing the vaginal and the oil. I'd also want your progesterone levels checked. I've never given someone 2 mils of PIO. That's a super high dose. So I would be very cautious about that, because if you get your progesterone level too high, you're basically on birth control. So make sure you get your levels checked.
What are your thoughts on endometrial scratch for the first FET?
The most controversial topic in all of infertility is the endometrial scratch. There are so many studies for and against, like I literally can't make sense out of it anymore. So bottom line, we don't know. Nobody knows. We don't know if it's a good thing or a bad thing. The majority of the most recent studies say that it is not beneficial. So we stopped doing it a while ago. I haven't done a scratch for implantation, God, maybe 5 or 6 years now, maybe even more than that. So it's been a very long time since I've done that. Yeah.
So, ready?
Always ready.
Anyone that starts a question with a "so" has got a story.
So, yeah, that's right. Yeah.
So,
So,
regular OBGYN patient of yours here,
okay.
no fertility.
Okay.
Are there any optional tests I can do to make sure baby is okay at 31 weeks pregnant? I know it's not scientifically based, but I have a bad feeling.
You know, okay, I'm going to go way out on a limb here, but I do believe in mother's intuition. I probably wouldn't be alive if it wasn't for my mother's intuition. So I think that if you're worried, you should either come in to see us or you should go to OB triage. So if there's ever a concern because you think something's wrong, go get checked out. Oh, especially in Canada where it's free, go to the hospital, let them check you out. Yes, you might wait a little while, but we don't want to take any chances. And obstetrical triage, you usually don't have to wait that long. So go in, get the fetal heart rate monitor. If we need to, we do an ultrasound. If we need to, we do blood work, whatever we have to do. And if there's issues, then we deal with it. So I would definitely recommend to anybody, anywhere, if you've got concerns about your pregnancy or your baby, go get checked out. I never, ever discount or downplay a patient's concerns. I may tell them they don't need to worry because what they've told me does not merit concern, but I'll still listen to them and hear them out and validate their concern and then say, okay, I hear you, I understand. That's not something that you need to worry about. But I'll never ignore them and say, yeah, I don't need to hear about that. Like, we always have to listen and we always have to take it seriously. And listen, mother's intuition is huge. My instructor, Dr. Renato Natali, probably one of the smartest guys in obstetrics, now retired, wonderful, wonderful human being. He used to tell us, if the mom comes in at term and she does not feel the baby moving, deliver the baby. Even if everything on the testing looks normal, deliver the baby, because she's been feeling the baby move the whole pregnancy. Now, all of a sudden at the end, she's not feeling it. Something is wrong, whether you can detect it or not, get the kid out. And I'm happy to say I've done that every time and saved numerous babies that way. So, we'll find out there's tons of meconium. They were becoming acidotic. Something was wrong. The cord had a knot in it, whatever. So, you know what? If you have an intuition that something is awry, you let us know and we will deal with it. For sure.
I think that's a great answer.
Thank you.
I liked it. Does MTHFR impact FET protocol?
Yes, you need aspirin and heparin, and you need methylfolinic acid instead of folate.
How much vitamin D should you be taking before ER? I'm doing 2,000 a day.
Yeah, I would want to check your vitamin D levels and titrate your dose based on your levels, but 2,000 is like minimum. We have some doing 4, we have some doing 50,000 a week. We have some on 2. So it depends on where your levels were at. If you were just insufficient, so that's between 50 and 75 nanomoles per liter, 2000 is probably enough. If you're deficient, probably 4. If you're deficient taking the 4 and it's not working, you need the 50,000 per week.
Where'd the sun go? Do you know?
Where did the sun go? Apparently went down to Miami with you.
Oh, I took it with me. Yeah.
Yeah. Packed it in your suitcase and snuck it off to Florida.
Absolutely.
Yeah. Did you say hi to Ron DeSantis?
Oh, President DeSantis.
President DeSantis? Yeah, that's right. He will be president. Although apparently he may not run. So who knows?
You never know.
Yeah.
American politics is a circus. What week in pregnancy do you recommend patients with a desk job go on mat leave?
Oh, great question. Whenever you want. So the earlier you go on mat leave, the longer you're on mat leave into your pregnancy. And so the problem with that is it means less time with your child. Most moms want to try and maximize the time that they have with the child. So they try and hold off on the mat leave till the very, very end. As a general rule, I kind of encourage women to stop when they're around 37, 38 weeks, give them a little bit of calm before the storm, so to speak. But we got women that want to go off when they're 24, 28, 32. I mean, whatever works for you is fine. Just remember, you're going back that much earlier on the flip side of it. So your baby may not be 1 yet, and you're kind of missing some of that most fun time with the baby because you took it off earlier in the pregnancy.
Happy Sunday, Dr. VNT.
Happy Sunday.
Can you explain DNA fragmentation?
Yes, although we need to connect, and I don't think we can do that from this, can we?
Oh yeah, with your iPad? You want to use your iPad?
Can I?
Why don't you try?
Really?
Yeah, that's worse. Let me see.
I don't know if it's charged. Oh, forget it. It's not charged.
Not charged.
Not charged. I saved you. Yeah, it's totally not charged. It's dead. That's what happens when you leave over Christmas. Okay, so you guys all know how DNA is like a ladder, right? There's strands with connections, and then you take the ladder and you literally like twist it. So it's called a double helix, which are these spirals of each strand with the connections in between. So if you think of a ladder, like let's just unwind it. So it's just straight up and down now, like a normal ladder. If you think of the side pieces, not the rungs, but the side pieces being broken every few rungs, that's what DNA fragmentation is. It's literally cracks in the DNA strands where there is breakage, and it hasn't been repaired by the normal DNA repair mechanisms. So the more of those fractures you have, the more unstable the DNA is. The more unstable your DNA is, the higher the chance that you will have a miscarriage, bad blastulation, bad fertilization, and so on. Hopefully that explains it. Causes: smoking, drinking, drug use, obesity, chemical exposures, sitting for too long, so truckers, sometimes farmers, cyclists, all of that stuff. Excessive heat, electromagnetic radiation, don't put your laptop on your lap, cell phones in your pocket, that kind of thing.
Hello, Dr. VNT. What is Luveris and when should it be started with the stims or day 6 onwards?
So Luveris is a recombinant LH hormone. So we are normally giving patients FSH during their cycle. So that's something like Gonal-F, Puragon, Recavel, all of those are the recombinant FSH drugs. And then the Luveris is the LH. So normally in your cycle, you have FSH go first. That stimulates the egg to grow. The egg gets to a certain size. You're making a certain amount of estrogen. Your brain recognizes that, says, oh, time to send out the signal to release the egg. That signal is LH. So it spikes the LH level. And then once you've spiked that LH level, you release the egg. So there is a background low level of LH, and Luveris is just that LH. made synthetically in a lab. When's the best time to start it? You can actually start it with the start of the cycle. You just don't want to give too much and the egg quality is terrible. So you want to, it's different than using Menopur. Menopur is supposed to be half-half with your recombinant, like Gonal-f or Recaval, but Luveris you have to use a lot less. So it's like 2-to-1 or 3-to-1 ratio. So that's the way we used it. Well, there was no Menopur, but Menopur is back now.
Hi, Dr. VNT. 2 failed transfers, 1 fresh, 1 PGT normal. I only have 2 embryos left. Would you recommend anything before proceeding with transfers?
Yeah, a full consult with a qualified RE who will go through all of the history with you first, figure out why your PGT normal didn't work, offer you whatever testing or treatments there are that can help you, and then go through with your transfer. So those are some of my favorite cases because we frequently figure out what's wrong. I tell patients and then it works. So just contact info@drvictory.com and we can go through it with you and figure it out.
Can CD138 biopsy be used instead of Fertility?
No, because there's no agreement on how high your CD138 level needs to be to actually qualify for a diagnosis of chronic endometritis. So I'm not a believer in that.
How long should you testosterone prime for DOR with DHEA?
Great question. Nobody knows. Some studies say 6 weeks. Some say 2. We just use 2. 6 weeks of testosterone, and I'm partially going to turn you into a dude. So I don't love doing that. So we usually just do it for 2 weeks prior to and then through the stim.
What KS your standard medicated FET protocol? What is your standard medicated FET protocol?
I don't use a medicated FET protocol. We don't use estrogen and progesterone. So we use letrozole, lots of supplements, double progesterone, and we don't trigger usually. And we measure our progesterone levels. So, and we use Lupron prior to that. We use antibiotics and probiotics in every cycle. So that's the way we do it. Pretty much every single one of our YouTube videos has me outlining our standard protocol. So check it out on any of our videos. We go through it there, but it's basically Lupron, then we do day 3 to 7 letrozole, antibiotics, then probiotics, melatonin, not coenzyme Q10, melatonin, vitamin D, your prenatal vitamin, and the fish oils. We wait till your lining is 8 millimeters. We'll use a combination of progesterone and oil and vaginal progesterone. We wait 3 days. We measure your levels, make sure it's in the right range. Morning of day 6 or afternoon of day 6, we'll do your embryo transfer for a day 5 embryo, and then day 7 if it's a day 6 embryo. So that's our protocol.
Happy New Year, you two.
Thank you. Happy New Year to you too.
When is Fertility recommended, and can it be done without a doctor's visit?
Yeah, you don't need a doctor's visit. You can just contact Fertility. I do recommend you tell them you're our patient because it's cheaper. And then they'll offer you a combo for the testing. When can it be done? I mean, I don't think it's necessary unless you either have very, very few embryos, A, a history of previous failures, B, or you have already failed, 2 embryos out of a recent cycle you've done with whoever. So you don't have to do it automatically. Like, it's not something we recommend for everyone. But it's a reasonable series of tests to do. So if you want to make sure everything is perfect, that's the way to do it.
What happens when you fail a FET and a standard protocol of estrogen and progesterone on euploid embryo? What change would you recommend for a second transfer, assuming no immune issues?
I'd get rid of the estrogen. So letrozole protocol. If it's euploid, I would recommend you look at the Fertility testing. If you don't want to do that, PRP, human growth hormone, Neupogen, vaginal Viagra, all the things that can help you with failed FETs. We have a failed FET video on our YouTube channel, so check that out for sure, because we talk about all the things you can do when you failed an FET. So check that out. It's all up there. And we talk about I think it's the top 5 things to do for a failed FET. Is it the top 5? I think it's the top 5. Yeah. So check out that video. It explains to you what your options are for a failed FET. I think we hit 9 o'clock, right?
Yeah, you did.
All right. Should we call it a Sunday night?
Oh, it's definitely a Sunday night.
It is Sunday night. I got to get home and pack, so I think we will call it a night. Anything major we have to answer? Were there like 2 million questions?
There was actually a lot of questions. People were ready for it. They missed you. You were missed.
We were missed. I'm sorry, guys. I do have to go and pack, and my wife will likely kill me if I don't get home. So if you want to see me again next week, it's best I get out of this session and go to the next one. So Happy New Year again. Thank you so much for watching. Super exciting year. We're going to do some different things this year. We're going to start bringing more people on the show so you can hear other people's opinions and views, and maybe some differing opinions from ours. We will try and continue the comedy sessions that we have here every week. And as always, if you have specific questions or you have a topic you want us to discuss, let us know. Give us some feedback. Tell us how you feel about the show and what you think. And if you think there are ways we can improve it, let us know that too. We're happy to do that as well. So thank you so much for watching. Hope 2023 is an amazing year for all of you guys. Look forward to learning, growing, and experiencing with you. And from myself, Dr. Victory, and Tarek on the other side of the cameras, have a wonderful, wonderful evening. Take care, guys, on TikTok. I'm sorry I couldn't focus on you. We have to use 2 different cameras. So Happy New Year, happy holidays, stay safe, and we'll see you guys all again next week on Fertility Factor Fiction.